That's why I put the topic here itself is aims used for analysis of anesthesia risk, right from preoperative to intraoperative and postoperative phases. Okay, so this is what you have to understand from the title that has been given here. But in the exam, they will give only this anesthesia information management system. This is all will be the question that will be asked. But you have to understand these are all the things that you have to write about it. So it's a system using computers to procure, store, and analyze data, and an easy way to analyze the morbidity and mortality and thereby the risk of anesthesia. This is the main purpose of this aims. Instead of manually writing and recording all the parameters, you use the computer system to procure, store, and analyze all the data. And several investigators like Sanborn and colleague, Reach and colleague, they have done extensive work using this particular technique. And other approaches to find the root cause of morbidity and mortality are, what are they? Confidential inquiry into perioperative death. This was one of the methods which is used prevalently in the European countries. After something has happened, you go and make an inquiry. This is called the confidential inquiry. And that is how you find out what is exactly went wrong and how the problem happened. Another is the ASA closed claim study, which also used in the USA, and Australian incident monitoring study. All these things were used for finding the root cause of morbidity and mortality. Now, risk factors associated with increased odds of dying within 7 days. So earlier it was thought only first 24 hours is the responsibility of anesthetist to, if anything goes wrong, it is the responsibility mainly unless it is a glaring or overt surgical mistake. Like for example, you are doing a Whipple's and you cut the aorta and the patient dies on the table because of bleeding. That is not considered as an anesthetic death. That is a surgical mortality. Whereas in if everything goes all right and then patient dies within 7 days of postoperative period, most of the time it is all counted under the anesthetic deaths. So what are all the variables that were taken into consideration? The age of the patient, the sex of the patient, physical status, and surgery related, anesthesia related. So this is how the risk involved were taken, and these are all the odds of dying within 7 days, out of which the anesthesia related is 1.60, surgery related is 3.82 on major risk patients, and the various causes are also given here. Now, special patient groups which also fall into this groups are the obstetric patients, pediatric and geriatrics, where the risk and morbidity and mortality are higher. Now, what are all the risks to the anesthesiologist if some morbidity and mortality occurs? It is a medico-legal risk or the allergic reaction, needle stick injury, disease transmission, and drug dependence. These are all the risks for the anesthesiologist also that is happening. And functioning aims during perioperative period, documentation in action. So it provides the preservation and documentation of reliable data and foundation for making decisions at the point of care. So right from preoperative time, you can plan everything. So it is somewhat similar to crisis management resources, what we discussed earlier, but here it is more of an elective thing. It doesn't come under the acute crisis situation. And the aims collect data from devices such as patient monitors, anesthesia machines, even drug infusions which are going on, and clinical events that are happening like anesthesia induction, patient positioning, insertion of invasive lines such as central line, catheterization, arterial line placement, start of surgery, end of surgery. All these things what we were manually writing down in our anesthesia record has now been automated by the information going into a computer and getting stored, and what blood products were used, all are which were manually documented are now done by the computer. So as data is stored in record, a clinician can access, review, and change it using the user interface. And patient risk stratification is a key aspect of AIMS, which can be determined using saved patient data and algorithms such as the modified Lee Goldman index. So here we all of us are very familiar with the revised Lee index for cardiac patients. Similar to that, there is a Lee Goldman index. So by going through all the preoperative stored data, you can introduce or write in the case sheet in the documentation itself that what is the risk involved in that particular patient undergoing a particular type of surgery. And then manual data entry case events like case timings, drug administration, airway management events, regional or nerve blocks, and automatic transcription of vital signs and ventilator data are all now computerized record or all part of intraoperative charting. So preoperatively, as I told you, we can assess the patient and give the correct ASA classification and the risk involved. Intraoperatively, what we were manually doing that can all be now, except the case timing start, we have to enter. So that is what is called the manual data entry. Nowadays, all of you are very familiar with WhatsApp texting. So similar to that, there will be a keyboard where you can enter the timing, the name of the drug, everything can be manually entered by the anesthetist at the start of the surgery. Once you then put it on a particular mode, it will automatically grab all the data from the monitor and ventilator or the infusion pump, as I said, and it will record everything in the computer, and it will be reproduced whenever you want to see that again by the click of the button. So AIMS facilitates the continuous recording of anesthesia in real time during cases. So every second, every minute, depending upon the it will be recording all the time, so that you can pick it up at any point of time you want to see what happened. For example, when they do cross clamping for aortic aneurysm, you can see what was the BP before clamping, after clamping, and every minute or every 30 seconds, if you want, you can set the timing and get the whole thing, which you cannot do as a when you do it manually. So the real-time recording can be done, and AIMS allows post-operative documentation in recovery units like PACU and ICU. So this advanced technology allows to develop skills among clinicians, nurses, and other hospital staff effectively to carry out particular tasks. So when you see this information, you are able to immediately pinpoint and find out what exactly is the problem. And some AIMS support the clinician by providing an algorithm. So as you get more and more data, it can be analyzed and you can get an algorithm as to what to do. So even a junior or a novice who is not that much experienced like an experienced clinician, once you give them the algorithm, then they can follow it up so that it can be beneficial to the patient. So dosing calculations based on patient age, weight, renal function, all these things will be automatically given to you. What are the advantages? They are very useful for patient safety and quality care, documentation, operations room management, and based on that, you can corporate hospitals can do the cost calculation also, how much of expense is being done for the patient, and it can be fed to the insurance companies for reimbursement, and it can be used for clinical research also. And AIMS can give good return to the investment in 4 areas. More effective staff scheduling. So you can utilize the staff nowadays, getting the qualified nursing staff and other people for the hospital is becoming very more and more difficult. So by utilizing the manpower correctly, you can get the most efficient work done, and the lowest anesthetic drug prices, better charging, billing, and appropriate hospital reimbursement of all these things can be done according to using this information. Then how to do the clinical support, clinical decision support is by protocols and guidelines or algorithms, as I said, as well as for administrative processes. and aims to improve various elements of clinical performance and patient care, especially when they are incorporated into clinical workflow consisting of evidence-based recommendation. And it will facilitate research, multi-center study projects. You can exchange the data with other institutions and do a multi-center research project, especially when a rare case is being operated in only a few centers. Then the total number of cases may be much less. So by combining with the other centers, we can produce a good quality sample size and produce a better project and anesthesia practices. Then quality assurance has made significant improvement by using AIMS. It enables recovery of unbiased and error-free data from vast database. And legal protection is also there, can be involved in medical legal matters where AIMS can assist in the court by giving the data. And then it can prevent the unfavorable outcome to the anesthetist also. And it plays a very important in risk management strategy by providing complete legal and contemporaneous recording. Then organization of the anesthesia department, that also can be done. Various hospital specialties necessitate anesthesia care. So you can use AIMS to provide information on operating room time, surgery duration, anesthesia occurrences, and this will be useful and estimating medicine usage, equipment usage, and other inventories. And with reliable data and feedback suggestion, it can give a formulation of how much staff members you require, how much monitors you require, how many staff you require. All these things can be done by seeing how many number of cases have been done in the previous 6 months or 9 months, and accordingly you can plan the organization of the anesthesia department. And this will also help in the administration also, and it will be making cost effective, even though, as Sujata said, initial cost is installation cost is quite high, but over the period of time, in the long run, it will become cost effective because it is a one-time expense. After that, it is going to run for life, unless with a small service requirement, AMCs and other things. And tracking patients' movements during hospital stay also. For example, patient will be admitted in ward A in the preoperative phase. Then he goes for a surgery. Then he will be in the post-operative care for some time. Then he will come back. At the time, ward A room which he occupied on admission will not be available. He will be put in ward B. So the same patient, you can track where all he has gone by using this anesthesia information management system. So patient details with regard to location, sequence of preoperative events, hemodynamic recovery are automatically documented. And there is transparency between the clinicians and the relative of patient. But all, after having talked so much goods about AIMS, there are some drawbacks also. What are the drawbacks? Some physicians are still hesitant. They all say the computer can fail, or some people are very not savvy with the computer technique, so they don't want to use that. So they are still hesitant, and they are still happy with the paper records. And the high expense of installation is another curtailing factor. Many hospitals don't want to spend too much money on that. And many studies have proved AIMS have become more accurate and more reliable than paper records. This is a very important point that you have to remember. And return on investment outweighs the cost, even though the initial cost is high and clinicians' hesitancy. These are the two things which are holding back the AIMS from becoming a routine affair in all the hospitals. And vendor who installs, or the companies, or the persons who are supplying these computers for AIMS management, they have certain they have to ability to handle the catastrophic incident. For example, there may be a server failure. All electronic equipments, they have their own faulty problems, and power loss or network interruptions. These are all the things that can go against the computer usage, as well as their redundancy method. So they, as you all know, Nowadays, phones are becoming more and more updated. You buy one model, within 4 months, another model is coming. Within another 2 months, you get another model. So, like that, computers are also getting upgraded quite frequently. So, what you buy in 2024, you become obsolete in 2026. Another new model will come with more features. So, that is another drawback that you have to go on for upgrading that. So initial installation is high, then upgrading will become costly. So that is the main factor for the AIMS not becoming so popular. Then the system stability, user interface, and system responsiveness and security. People can steal the data. Any computer work, cyber crimes are there, and people can steal the data. Network connectivity should be highlighted in AIM software and hardware demonstration. So these are all the drawbacks that we have to remember with regard to the AIMS.